So unfortunately, Dr. Francomano, I know a lot of people want to hear her. Unfortunately, she's unwell. So I get to be her pretend person. So, so I'll do the best I can. I was just looking over her slides to make sure I had some idea. Now, some of the stuff I can't tell her thought processes, so I'll just say whatever I think is appropriate, and it might. And Dr. Henderson can help me too, because he's heard this talk before, right? I bet you have.
Yeah.
Okay.
Well.
If I say something wrong, you just. Okay. So for those of you guys who don't know Dr. Francomano, she's one of the pioneers in terms of looking at the complexity of Ehlers-Danlos. And so she has been a board member, as has Dr. Nish and Dr. Henderson and I, for TCAP, which has been wonderful. Oops, sorry. Stop. So, as you can kind of tell from all the different subspecialties that have been up here talking today and some in other places, that EDS is a multi-system disorder. And I think, embarrassingly, I have to think back on my own career and realize what I missed because I didn't get it. And I had some idea about joint hypermobility syndrome because I'm a neuromuscular doctor, but I didn't get the complexity of this particular disease process. So chronic pain and chronic pain, I think, is, people just think, oh, it's just musculoskeletal, but there's a lot more to it. The fatigue that folks with this whole syndrome is horrific, and it's not pull your bootstraps up, not, buck up, it's really horrific. And as Dr. Nish said, a lot of these patients get, you have anxiety, depression, you have a conversion disorder, and you actually may have all three but still be really sick. So I think that's, part of the problem too, that some people have some mental health care issues, and whether or not it's primary or secondary is hard to know. So I don't like using the term functional gastrointestinal disorder because that implies that this is not an organic process, but the GI docs can't get past using that term. And when you tell somebody, if somebody saw the diagnosis on the paper, they would automatically just say, you're whacked. So, and not really pursue it. Dr. Francomano wouldn't speak that way, but she's much more proper than I am. Chronic headache disorders, pelvic dysfunction, exocrine gland dysfunction, cardiovascular, immune dysregulation. And I think, the bottom three in blue, for me, learning about mast cell dysfunction is something that I'm just now getting started on, and realizing how much of that might be playing into my patients' problems, and bleeding and clotting disorders, and neurological complications. Oops, sorry, I keep doing that, sorry. Let's see. So this is a paper from 2012, but this is a good review paper, and it shows about how a disorder with many faces. And we were just talking about this in terms of people that I have that have multiple family members and how different each of the family members can be. So just because one does this doesn't mean the other one's going to do that. So EDS classification, so there's lots of different kinds. Most of them are most of the top four are kind of the common ones, and then the rest of them are very uncommon. And so some of the EDS different subtypes can be diagnosed with genetic testing. At the EDNF meeting that I went to in July, the geneticist from Baylor says that he's tested 2,500 people with the joint hypermobility type. Nothing overlaps or correlates, and so, which I think makes it difficult because we don't have a good. There are some that have 10X and X as a possibility. So joint hypermobility and joint hypermobility syndrome, and I'll show you how you do that on the next slide. But there's Beighton scores, which is just looking at joint hypermobility, and then there's Beighton scores that look at this whole syndrome. So EDS hypermobility type and joint hypermobility syndrome have overlapping criteria. I know Dr. Francomano believes they're the same disorder, which I think makes sense. So one of the things that happens as you get older, you get less hypermobile, even if you have EDS. I've seen some numbers where as many as 35% of people don't currently have joint hypermobility, but historically have hypermobility. So it says, can you ever now or ever place your hands flat on the floor without bending your knees? Can you bring your thumb to your forearm? Now, most people don't do this as kind of, but unless they're doing it as circus tricks. They'll show people all the things that they can do, you know, with their stuff. And I remember seeing when I was in high school, this very, very contorted person with arms and legs all wrapped up and all this writing all over their own skin because they had mast cell activation disorder. So they had, so it's like they didn't know what it was, but they knew it existed. And then amuse your friends, and how many dislocate, and do you think you are double jointed? So here is the Beighton Score. So hyperextension at the elbow, bending your little finger back farther than 90 degrees, getting your thumb to your forearm, hyperextending at the knee, also known as back knee, because some people say, well, yes, I do that, but they don't realize it's because they have joint hypermobility. And then and you can see somebody back knee when they put their hands on the floor, because most of the time they'll back knee when they do that. So for their Beighton score, it's greater than 4 out of 9. And for joint hypermobility syndrome, 4 out of 9, and they have arthralgias for greater than 3 months in 4 or more joints. I have seen one paper talking about kids where they looked sequentially at 500 children, and 30% of them reached criteria for joint hypermobility syndrome, and they suggested that the younger kids would use higher numbers. But so that's just something that I kind of put in my thinking process too, that kids are more hyperextensive just by the nature of being young. So for minor criteria are dislocation, soft tissue rheumatism, which is basically inflammation around a joint, the marfanoid habitus, stria, hyperextensibility, thin skin, droopy lids, and abnormal shape to your eyes, and then varicose veins and hernia. So there are a lot of things that a lot of people have. And do they have joint hypermobility syndrome, or do they have Ehlers-Danlos hypermobility type? So using the other criteria, the Beighton criteria, so you have to have 2 major criteria and 1 major and 2 minor criteria. But there's always the whole concept that if you have a first-degree relative, then you still can come under this category, because I do have families where one kid is hypermobile, one kid's not hypermobile, but the mom's hypermobile, and they have similar symptoms, so it still can fit under there. So these are the skin features where, oops, let's see this way. Yep. You'll see the stria, you'll see the extensibility, and you'll see other changes here in the skin at the shoulder. So pain in Ehlers-Danlos syndrome. I mean, that's one of the more difficult things to take care of anyway, because you have so many different kinds of pain, and trying to figure out what one to try to fix, and because a lot of times it's a vicious cycle. I have musculoskeletal pain, therefore I have headaches. I have headaches, therefore I have migraines. I have migraines, therefore I'm not sleeping, and so it's just a vicious cycle in terms of how to deal with stuff. So you can have muscle pain, myofascial pain, neuropathic pain, headache, abdominal pain, pelvic pain, and complex regional pain syndrome. So this is a brief pain inventory, the short form. I've seen some of Dr. Francomano's her write-ups, and it doesn't have the short form in there. It's got the 5-page long form. It's pretty impressive to even go through the process of filling all those out. So when you look comparing joint hypermobility and classical Ehlers-Danlos, there's certainly similarities in terms of what their pain scores are like, but the hypermobile type does seem to have higher pain scores. It seems to be also that as you get older, and I think that's probably just recurrent stretch and recurrent traction, that you have more difficulties with pain. The chronic fatigue syndrome, it is profound, disabling exhaustion. I mean, I know that I did this before, and I look at people and, well, you're depressed, you know, but the other thing is, just because you have psychiatric illness doesn't mean you don't have a medical illness, so I didn't just blow them off, but still, they look depressed because they're so fatigued, they just look like they just don't want to have anything to do with the world, because they don't on some level, because they feel so bad. And this, I think, is more disabling of pain, and you know, I think you were talking some about that. I think the fatigue and the orthostatic stuff and together make it so difficult to exercise, and I think that's a big problem. And again, sleep disturbance is a major contributor. And you can have other possible contributors: adrenal dysfunction, thyroid dysfunction, and potentially mitochondrial dysfunction. So this is a great shirt, huh? That's awesome. So when looking at the sleep cycle, you know, stage 2 is where we spend most of our sleep. However, your restorative sleep is your deeper sleep times. And so I've seen people who have profound sleep disturbance where they just don't ever get deep sleep. Some of the kind of classic thing is obstructive apnea. They get light sleep, and then they get into stage 2 sleep, and then they obstruct and they wake up and they start over. So they don't ever get into deep sleep because they wake up from their obstruction. As they go into deep sleep, they snore, and unless somebody goes like that, you know, they can have apnea. So feeling the effects of sleep deprivation, certainly as a doc, all these I recognize, but it's really, you know, I think the irritability and the cognitive impairment, I don't know about the moral judgment part, but but still there's just so much that goes on in terms of effects of sleep deprivation, and in reality, this is why they limit the number of hours that residents can work now. So they can only work 80 hours a week. Now, there's nothing to say that I can only work 80 hours a week. They get to go home and I'm still working. So, but they only have to work 80 hours a week. So GI complications in EDS, you know, difficulty swallowing, difficulty having food go from the back of your mouth to your stomach, esophageal spasm, reflux, hiatal hernia, which is, you know, that's a connective tissue process, gastroparesis, which means your stomach doesn't empty very well, bowel dysmotility, which is constipation more than diarrhea generally, but and then rectal prolapse. So when looking and comparing the classical, formerly known as type 1 versus the hypermobile, formerly known as type 3, you know, there are some differences, and I think you know, looking at emesis is a little more common in the hypermobile. Diarrhea is a little more common in the hypermobile, but a lot of other ones, there's pretty much the same across the board. So headache and Ehlers-Danlos syndrome, you know, people talk about migraines and they talk about tension headaches and or muscular headaches, and so they're really the right term from a neurological point of view is chronic mixed headache syndrome, because it's not like, and again, this is that vicious cycle. You know, you have a musculoskeletal component, it makes your migraines worse. You have migraines, you don't sleep, and that makes all your headache, you know, symptoms worse. So, but there are some other things that can, you know, be part of the headache in Ehlers-Danlos. So the muscular and the myofascial, you know, that is a lot of the things that the patients have to help do for themselves. I mean, I can send them to PT, but they have to stretch, they have to do ice, they have to do heat, they have to, you know, do range of motion kind of stuff to stay stretched out. And it's a funny posture that people have when they have all this. They roll their shoulders in, they stick their chin out, and I'm exaggerating it, but it's almost like a turtle, you know, they like this, and that just makes all of that worse. So it's like you have to stand up straight. You know, nobody stands up straight anymore except for people in the military. So you have to stand up straight. I always say, pretend there's a wire hooked to your head that goes straight to the ceiling. You need to keep your head up and your shoulders back. You can have TMJ dysfunction, and I think that just exacerbates the myofascial and the muscular component. CSF leaks, and honestly, that's one of the areas that I'm still in the learning process. Do you have any comments to make about CSF leaks?
Yeah, it's extraordinary how very few I've seen in the EDS population.
Have you really?
I know that there's a lot of talk about them, but I think most cases have presumed CSF leak as something else.
Okay. And then Chiari malformation we've heard about, and disruption of venous drainage. So there's a syndrome of chronic cerebral sinus venous insufficiency. So for reasons that I don't understand, in the neurological literature, they relate all that stuff to multiple sclerosis, and I'm just like, I don't get that. So I think even as in the neurological literature, this is not something that people commonly think about, and I don't know how the hookup started with MS in the first place. Symptoms of increased intracranial pressure. So I lived in Colorado Springs, and so I can watch the storm systems come over Pikes Peak and land on Colorado Springs the next day, and I could almost count on my fingers who's going to be calling saying their headache's worse. Yeah, and so I knew the barometric pressure has something to do with it, but it was really pretty impressive. It may act like there's a CSF leak, and as Dr. Nietzsche says, that some women report increased symptoms around their menses. So it can be documented by increased pressure on lumbar puncture or intracranial monitoring, but there's also other things like Chiari, disruption of CSF flow, or the venous blood flow. So something like Diamox, which is a diuretic, it can increase your chloride levels and decrease your bicarb. So if you're putting somebody on Diamox, you need to pay attention to potential side effects. So pelvic dysfunction in Ehlers-Danlos syndrome, pelvic pain, prolapse, bladder prolapse, uterine bleeding, sexual dysfunction, I think are things that probably don't get addressed as much. And so, I'm actually going to talk to the gynecologist when I go back and ask her how many Ehlers-Danlos patients she thinks she sees. Because that's actually been, an issue. My patients I'm sending to all the specialists, so we're all learning. So, which is nice. So I'm going to talk to Dr. Carjay when I get back, talk to her about it. So urinary symptoms, again, looking at the kind of things you can have: urgency, incontinence, frequency, and recurrent UTIs. And they're really all about the same in comparing the classical to the hypermobile. So exocrine gland dysfunction. This is an interesting one to me because this is one of the areas that I personally use as the concept of this is not a collagen vascular, and this is not a connective tissue disorder. I don't understand thyroid disease and connective tissue. This is, off-label. I personally think that the patients who have the EDS joint hypermobility syndrome that have all of this other picture, that they need another label. It's not just EDS hypermobility type. There has to be another label. And in the past, I have sent people for mitochondrial workups. So I have about 6 or 7 kids who have abnormal muscle biopsies with mitochondrial dysfunction. They don't have a mitochondrial disorder, but some of the patients act like surgery is a metabolic stressor, illness is a metabolic stressor. So I think there's something to that. I just don't know what it is. But exocrine gland dysfunction is common in mitochondrial diseases, just as an example. So cardiovascular manifestations, you can have mitral valve prolapse, aortic root dilatation, venous insufficiency, tachycardia, orthostatic intolerance, and chest pain that I think we've already heard a good bit about. And again, looking at the classic versus the hypermobile, they're really pretty much the same. I don't think 19 to 26 in terms of who fainted or not is that big a difference. So immune dysfunction. I think this is one of the things that the patients with Ehlers-Danlos know a lot more about than the doctors. And in fact, I think that's kind of a common mantra with the Ehlers-Danlos population, is that they have to educate their doctors about what's going on with them. And hopefully you have a doctor who listens. One of my favorite statistics is it takes 18 seconds before the doctor interrupts you. That's the average time before the doctor interrupts you when you're talking. So personally, I'm kind of a chatterbox, so I have to use my ears and also use my head going, don't talk, don't talk, don't talk. So I think you have to listen to what people are going on, especially when they're having so many different things that just like you kind of get overwhelmed with it. And so the patients know a lot about this because they've been dealing with it. So whether or not somebody has immunodeficiency, kind of more common autoimmune disorders like lupus or arthritis or psoriasis, Behçet's disease is uncommon but may be underdiagnosed, and mixed connective tissue disorder. And what's the overlap between these kind of autoimmune disorders and connective tissue disorders? Is this an antibody-mediated thing, which I think is reasonable to think. The other problem that some people with Ehlers-Danlos have is mast cell activation disorder. And in my learning about this, I'm wondering how much of mast cell activation disorder symptoms I'm calling dysautonomia. So that's where I'm kind of thinking about where I am going down the road. So there's a subset of patients who have mast cell disease. And I know at the Ehlers-Danlos National Foundation meeting in July, the person who talked about it, Dr. Maitland from New York, she says the problem with the Ehlers-Danlos patients, and unfortunately for patients with Ehlers-Danlos, like every other problem they have, the tests are normal, and so you must not have the disease. So I think that gets to be a real problem. But flushing and hives and anaphylaxis, so most patients respond to H1 and H2 blockers, which is Zyrtec and Zantac, and then cromolyn is another that works better for GI symptoms. Are you stressed or your autonomic dysfunction worse and you get mast cell activation? You get mast cell activation and your autonomic symptoms are worse. I think it's hard to know. So hematological complications, easy bruising, bleeding complications, von Willebrand syndrome. That's actually an interesting test to do because it plays into a lot of different kind of disease processes. There are clotting complications, and there is a gene that some people have abnormal, and there are people who have platelet dysfunction. I have not been able to get my hematologist to buy into this because there's a particular disease that the lab will only do it if they order it. I can't order it. So so I'm working on it. So everybody has to learn from each other, right? And they have iron deficiency and may have malabsorption. So neurological complications, I think we've heard a fair about just in our first 3 talks, but I think unless you think about them, then you're not going to think about it. I've been a little hamstrung where I am because I'm not the person with a knife in my hand. So if I think somebody has something but the neurosurgeons don't agree with me, I get hamstrung. So it's tricky sometimes because to get people to kind of work through this. I know the first patient I had that had surgery with occult tethered cord syndrome, it took me a year to get the neurosurgeon. It's real, she needs surgery, it's real. And it took a year for that to happen. So you have to have a neurosurgeon who knows about it, thinks about it, knows what to do. And so when you look at the autonomic nervous system, I mean, there are so many, this is kind of the flight or fight kind of side of things. Then this parasympathetic is kind of the opposite of the sympathetic nervous system. So autonomic dysfunction is postural orthostatic tachycardia syndrome, neurally mediated hypotension. It can be part of your sleep disturbance. It can come from endocrine dysfunction. It can, I mean, and they can play back and forth with each other. Gastrointestinal dysmotility and temperature instability. So most of my patients who have temperature instability are hot. I have one person who's cold, and I said, well, I can help you if you're hot. I don't know what to do with you if you're cold. I mean, she wears 3 sweatshirts in the summertime. So anybody have any experience with that? Any thoughts about that? Yes, sir?
Yes, it's very difficult.
That's what, yeah.
And they just really by accident. And they have a patient, this being cold was his major. The way I treated him with, of course,
Mm-hmm.
real-life medication. I treated him with pizza.
Okay. And,
He did good, but I checked his temperature. Amazing is you check their temperature centrally and you check peripherally their temperature.
mm-hmm.
Clearly they have low temperature.
Uh-huh.
And for him, he goes to college north, and it's just very frustrating.
Yes.
How when it's cold. And also the other problem they have is with any little, because their sense of temperature is different. Any little bit they think they have fever. This
Right.
Also, it doesn't take them much to start to feel I'm warm, I have fever.
Right.
Yeah.
And in terms of that kind of stuff, I'm wondering how this may be kind of a mast cell activation issue too. Some of it, because I have a patient who would go and get in the pool, and once she would get out, she would have brain fog for 2 hours. And she was already on Zyrtec, and I put her on Zantac, and it went away. So it's an interesting problem. But yeah, the cold, I feel bad when she comes in because I go, yes, it's a tricky one.
It's really common in the patients who got a diagnosis of mitochondrial.
Mm-hmm. Mm-hmm.
I actually see that more commonly in patients who carry
Okay.
a miter gene.
Uh-huh. Yeah, and the trick is about 75% of patients with mitochondrial disorders will have autonomic dysfunction too, so that's a big overlap area. So in terms of neurological symptoms, all these things are very prevalent in patients, no matter which type of Ehlers-Danlos they have. The tremors, and I think, I would actually call these involuntary movements because I would kind of put the tremor and the dystonia kind of under the same umbrella, but basically I think involuntary movement disorders. So some of these things like, where's Pam's not in here, but oh, there you are. Why do you have certain symptoms with certain anatomical problems that just don't make any sense at all? I don't know. So I know we were talking about that earlier. It's that once you just learn that it is, and you just accept that you're not going to figure out why, and just go on with it. Just make sure you know what it could mean. So the temperature instability, weight gain, and weight loss, I think, are part of the whole concept of the Ehlers-Danlos patients. Psychiatric symptoms. A lot of these patients have mood swings. Is that because they feel terrible, because they're not sleeping? Are they withdrawn? They look depressed. I think, I know sometimes I've had patients come in and they've heard for their whole life that they're crazy and to go away, I think that's really a secondary phenomenon. So when I say, well, the first thing I tell them, I said, so you might be what I call little c, little crazy, but you're not big C, big crazy. So, and I think, that it's even that just people just feel better that somebody's going to believe them and listen to them. The anxiety and depression, it's not all a secondary phenomenon. There seems to be some intrinsic mental health care issues in patients with Ehlers-Danlos. And the ADD, I think, is also true, but I would also say that that could be from sleep dysfunction. Because whoever they are, they say that 15% of patients with a diagnosis of ADD have a sleep disorder. So drug metabolism, I think, they don't metabolize drugs like they should, and certainly when some of my patients have gone to other institutions, if I talk to somebody there, only at least 5 times I go, well, you know they need more pain meds than regular, right? You understand they need more pain meds than regular, right? You know, and so just to kind of convince them, it's like don't relatively underdose them just because they need more pain meds. And so but you still have to be, as our Genelex lecturer, you have to be thoughtful about what you're doing. But I think that's one of the common things with the EDS patients is they need higher doses than anticipated doses of analgesics. So Ehlers-Danlos syndrome can be disabling. We talked about the performance scale status. Dr. Francomano very kindly left the bottom one off, but it was on Dr. Henderson's slide, and it cracks me up because 0 is dead. So she, I'm sure that's why she took it off, because that's kind of creepy. So I mean, you look at the kind of things where, where do people function? And, if you get to where you're in these 60s and 70s, I mean, look at what it's like. I can care for myself, but I can't do regular day-to-day activities. I need sometimes somebody to help me, or most of the time I can take care of my needs. And that's where a lot of people with this whole syndrome live. And that's not really a great place to live. That's not very functional. I mean, you get housebound. You don't have enough energy to go do stuff. If you make it to school 3 days a week, that's a big success. And that's not really a great place to live. So, can't connect the issues, think connective tissues. So I think that's true. And as a neuromuscular doctor, for what I tell the neurology residents, if you have multi-system dysfunction that you don't have any idea what it is, then think mitochondrial. And so this is the same kind of thing. If you have multi-system dysfunction, think connective tissue disease. And I think that's something that everybody needs to kind of put in their hat, as they say. All right. And these are all the folks that helped Dr. Francomano, and I certainly appreciate all those folks that help her, because that's great.